addicted to Percocets, and it was becoming a hindrance on my life. I got a family, I got kids to live for, and the way I was going just wasn't sufficient for everybody else around me and myself.
I got shot a couple different times, probably 4 different occasions. So each time the doc gave me Percocets, but the first time I was hooked. But I don't know, ever since then I've been chasing.
As the opioid epidemic continues across the country, few cities have been hit as hard as Philadelphia. In 2019, Aubrey Whalen wrote for The Inquirer that Philly's overdose deaths rose again in 2019, especially in Black and Latino communities.
In the city of Philadelphia, we have opiate epidemic out here. People are dying more and more every day from the abuse of opiates.
Every time you turn around, you have a lot of individuals come in here who are high off of opiates, who've gone through withdrawal symptoms. You see it every day.
Some patients, unfortunately, they're so high, and despite what we try to do here, it's just not enough.
The Philadelphia Inquirer recently published an article about how Philly's overdose crisis still needs attention amid coronavirus, stating that the coronavirus made the already hard work of overdose prevention even more difficult. That is what also makes this overdose crisis all the more urgent.
So the Philadelphia Department of Prisons around 2008, early 2009, implemented a 4-hour intake process.
One of the reasons it is a good thing, like say we do have a patient that's withdrawn, to let that patient sit for 6 to 8 hours, they could be dead in 6 to 8 hours.
And so it's a concerted effort that you need medical, you need behavioral health, you need security staff, all on the same page, because the ultimate goal is to make sure that those folks that are coming in that 4-hour window are properly assessed, classified, and moved out of the receiving room so that they're not held in there any longer than they need to be.
The intake process includes that when a person arrives here, they're evaluated immediately by security using a series of a few questions related to medical care.
Mr. Khan, are you coughing up blood or bleeding?
No.
Are you over the age of 18?
Yes.
Any police-related injuries?
No.
If a person is injured, if a person is suicidal, if a person's bleeding, they will get bumped up to be seen by medical immediately.
There is a pre-screening questionnaire administered by a registered nurse. The pre-screening questions help give an overall background to the patient and help to navigate their possible treatment needs. Questions range from, do they own a vehicle, to is the patient asthmatic? Additionally, a urine test is done to check for sexually transmitted diseases, and people are also tested for HIV, Hep C, and TB at admission. The jail checks the last 3 months of the SureScripts pharmacy database for evidence of recent prescriptions to give it a heads up about illnesses that an inmate may not report. This database records electronically submitted prescription information and is estimated to cover 70% of all prescriptions written in Philadelphia. The data also help provide bridge orders at intake for inmates receiving psychotropic meds in the community prior to incarceration, so the jail can ensure they continue to have access to their prescribed medications.
We have to complete our evaluations at intake within 4 hours after the person gets off whatever vehicle brought them to the facility. That evaluation is a series of questions administered by a registered nurse using our electronic medical record.
We ask questions about mental health history, and their dental history. Based off how they answer those questions, our clinical rule engine, it would trigger the system to schedule appointments.
Since this video was filmed, the jail has also had to respond to COVID-19. It was able to embed COVID screening into its 4-hour intake. As a result, some new procedures put into effect have not been captured in this video, the major one being measures to protect staff and detainees from infections. For example, the video captures a detainee being interviewed before COVID-19. On the right, a new cut shows what that now looks like during the current epidemic. New intake questions concerning COVID-19 were added last spring to the medical intake. These include questions if the person has traveled overseas within 14 days or had close contact with anyone under investigation for COVID-19. Does the person have a fever? Any noted lower respiratory symptoms? Cough, shortness of breath, shaking with chills, muscle pain, headache, sore throat, and loss of taste or smell. Thanks to advanced testing equipment, inmates and intake are tested immediately once they reveal their symptoms. The test is ordered by a physician or nurse practitioner, and then the medical staff perform the test. All COVID-19 positive cases require isolation for 14 days.
Have you gone through withdrawal before?
Yeah.
When's the last time you ate something?
Last night.
Okay. Was it food, liquid, both?
Both.
When's the last time you had heroin?
This morning.
How much of heroin do you use a day?
Like 12 bags.
How long have you been using heroin?
Long time.
If they come in and we know that they abuse opiates, because that's part of our question as well, the CRE will trigger appointments for 5 days a week, 3 times a day, so that the patient is evaluated by the nurse for withdrawal symptoms.
Are you having any withdrawal symptoms right now?
Yeah.
Have you had withdrawal symptoms in the past?
Yes.
Let me see your arms. Stick your arms out for me.
So then we have an additional form where there's questions on their appearance and signs and symptoms that they may be exhibiting, such as vomiting, diarrhea, nausea. Are they able to keep still? Are they sweating? Do they have goosebumps? So despite them not willingly telling us initially, there's still signs that they can be exhibiting that we could see as nurses.
I didn't even know they had a Suboxone program. They were asking me about my symptoms, so I was just like, yeah, I'm sick. I'm thinking they're gonna give me some regular comfort meds or something. Next thing you know, they gave me something, and I felt a little better.
They told me more about it. They signed me up. I had an interview with a doctor, and she approved me for it. It keeps me focused now. I have no withdrawal, whatever. I don't even have the urge to want to get high anymore.
How you doing, sir? All right. This is the Medicated Assistant Program. This is basically for Suboxone. So this is the consent form. May you read this front to back?
Interactions with the patient usually starts on day 2 of their intake into the correctional facility. During the intake process, they have identified themselves as someone who abuses opiates. And that generates an appointment to see me in order to be evaluated and see if they're eligible to get the Suboxone. So they come in and I kind of basically just start from Mr. Khan, I'm Dr. Martin. Okay. I'm meeting with patients today who have an addiction to opiates to see if Suboxone is something that can work for you. It's not for everybody, so I'll ask you a few questions to see if you're eligible for the program. If you are eligible for the program, we'll give you the first dose of the medication today. If not, we'll just continue to give you some comfort meds, okay? Okay. All right. And how old are you, sir?
38.
All right. And what are you addicted to?
Xanax and heroin.
Okay. Did you start with heroin or did you start with like Percocets and Oxys?
Started with Percs.
Okay.
As soon as a person has taken even a small dose of buprenorphine or Suboxone, their symptoms are almost entirely relieved. So they suffer a lot less actually by our using buprenorphine or Suboxone as the first medication that we administer. We don't, once we have administered buprenorphine or Suboxone, we don't use palliative care medications. It's not necessary.
I knew that the program would help out with my withdrawal, and that's what I wanted to take care of first. I wanted to get through that first, and I knew that I was educated on the pill, being able to handle the withdrawal, make it easier for me.
It helped actually. It, took the craving away from the withdrawal away from Percocets. So it took some time to get used to, but every day I don't have the urge to use Percocets no more, so it takes that away.
With Philadelphia being the epicenter of the opioid epidemic, it was incumbent upon us to begin the MAT program.
In 2017, the city was experiencing, and still is experiencing, an epidemic that there were 1,170 some fentanyl heroin overdoses in that year. The mayor convened a task force to address that problem. There were 6 subcommittees, one of which was about criminal justice. I was on that committee. And one of the recommendations from the committee was to expand the MAT program to other medications besides methadone. The primary form of MAT today here is the prescription of Suboxone. We did shift from buprenorphine to Suboxone to decrease the risk of overdose. So we think we'll treat about 3,300 people this year with Suboxone. We think we'll have about 500 people treated with methadone, and a smaller number who will be on maintenance for Suboxone, people that have been in illicit programs in the community at the time they were incarcerated. We offer Vivitrol. What we think we would like to offer in the future is Sublocade, which is a 30-day injectable form of Suboxone.
One of the reasons why I feel like that the injection would be beneficial is because some of the inmates here have jobs. Jobs don't operate around medication times here. So if we were able to give them an injection and it's good for 30 days, we wouldn't hinder them.
Well, when I get out, I think I'm going to continue the program. I think I'm going to try to find somewhere where I can continue the program at, because I like it. I like it for me right now. I think it's helping me. So it's only one way to really find out, though. Right now, I'm in the place where I can't really do too much, so I'm kind of complacent. So therefore, I mean, I can say that it's helping me, but who really knows until I get out in the real world. And when I get out there, you know, as far as searching for employment and schooling and taking care of my kids, I just want to see if it'll hold up to that too, because I never really did it on the street. So
Once you leave here, we can submit this to get you Medicaid or medical insurance upon discharge. So sign right here.
Pretty much the next day or the day after seeing me, they're meeting with a discharge planner, and the goal there is to get them set up and referred to a program. So when they leave here with a packet of medicine, they have a program to go to.
I'm also letting you know that any medication you leave here with will most likely be in a blister pack. So it's in non-child-proof resistance packaging. So you have to keep it away from kids upon discharge. And I'll also be doing a history of physical. So you'll sign right here.
One of our employees from that unit will see them, make sure that they are signed up for health insurance so they can have that when they go out into the community. They also refer them to, if they are on our Suboxone program, they sit down and tell them where all the treatment centers are.
These are providers that we call centers of excellence. They do primary care as well as MAT. The reason why we have that done almost immediately after admission is because people leave here so quickly.
Patients are also given Narcan and instructions how to administer it if someone is overdosing.
If you think someone's overdosing, you turn them to their back, tilt their head back, and spray it in their nose. There's directions here if you forget.
And they are given a blister pack of Suboxone.
When they leave with that packet, there's no reason for them to go back and use, because they can continue taking their Suboxone.
We started in 2016. We were eventually designated as a Center of Excellence. We offer Suboxone, Vivitrol, and Subutex. We offer that at all 3 of our locations. Along with the medication, you have to do treatment as well, which is group and individual therapy. Well, I think one thing that's been working with our partnership is the communication. So the communication allows it not to be a gap in the treatment. If a person comes out and they're out of medication, a lot of times they will go back to using. There's a gap in their treatment and they may not follow up with treatment. So I think the partnership is what works to get them into treatment, because we're aware when they're coming, we're prepared for them to come, and we're scheduling them to see the doctor and nursing staff as soon as possible, so there's not a gap in their treatment.
The department has noticed a decrease in inmate deaths regarding opioid withdrawals, because with the 4-hour window, we're able to readily identify, assess, and begin the clinical opioid withdrawal scale.
The medicated assisted treatment program really has done a good job as far as treating the patients as quickly as possible and also returning them to the community with help.
I've been coming to jail for a long time. I just did 13 years in prison. And the condition of the people, like, it has changed for the better, for the most part, because of Suboxone. You know what I mean?
Recently, we were describing this new program to members of City Council. And the response from several was that they had experienced overdose deaths among members of their family. Their perception of what the prison can do, or any jail can do, is you get a population that needs care, that's not getting care largely in the community, and you have the ability to start them on a road that will, improve their lives and decrease their risk of death. And that this is an extraordinary opportunity. That's why we don't call it an illness burden, we call it an illness opportunity.
This is an opportunity for us to use incarceration in a meaningful way, in that you're giving folks the opportunity, you're giving them access to treatment that they would not necessarily have if they remained in the community.
This is the first place I've ever been on any type of treatment medication.
It actually controls my cravings. I don't even have the daily cravings to want to even get high. I can go about my days without even thinking about getting high, actually. It also helps me sleep too. So that's relief for me.
I feel like if we start in the jails and start giving them direction, start offering them services and give them options outside of, I know I have an illness and I'm just gonna go back and use. Being able to put them on a Suboxone along with the counseling that comes with it gives them an opportunity to change, because we're saving lives. Potentially we're saving lives, and that's what it's about.